Losing a baby by having a miscarriage is hard enough on its own. And then if you need to add in making a decision about how to remove the remaining pregnancy tissue, it can be completely overwhelming. I'm Dr. Monica. I'm a board-certified OBGYN and mom of 3. And in this video, I want to educate you about the 3 options that you would likely have if you need to decide on a way to remove pregnancy tissue after having a miscarriage. So if you're watching this video because you have suffered a miscarriage, I am so sorry for your loss, and I'm sorry that you're in a situation where you need to make this type of decision, but know that you're not alone. This is something that I do almost on a weekly basis because it's extremely common to see first trimester miscarriages and to have to talk about this management for how to resolve the pregnancy and remove the tissue. Now, this video certainly has trigger warning about miscarriage and discussing about fetal loss, but I really think it's important for everyone to be educated about what your options are if you still have pregnancy tissue in the uterus that needs to be removed. So a lot of times this is a situation such as in the first trimester where you've maybe had an ultrasound and a pregnancy is located in the uterus, but by some criteria or some way or another, it's been determined that the pregnancy is not viable. And this experience on its own can be very sad, full of emotions, it can be devastating. And then you still need to make a decision about, well, what do we do to get the remainder of this pregnancy tissue out of the uterus? And in my experience, these are appointments that are just really overwhelming because you're taking in so much information. You've just learned that your pregnancy is not viable. You get all this information about the options, and it can be hard to retain it all, and it's a very important decision to make. So I want to take you through the 3 options that there are for removing remaining pregnancy tissue. Now, these of course always depend on your individual situation. So there are different factors as to why you may not be a better candidate for one or one of the other options. All of course is an individual basis. This is a general outline of the options that you would have after a miscarriage. So option 1 is expectant management. So what this means is that you just kind of watch and wait. Your body should eventually notice the declining levels of the pregnancy hormone, which results in declining progesterone, and should respond at some point by the uterus contracting down on its own and expelling the tissue. So when the uterus does figure out that it's time to expel the products, what will happen will be cramping and contractions of the uterus, which then pushes the tissue out. This is generally described as either a very severe period or, as I sometimes say, like a period on steroids. So more cramping than what you're used to with a normal period, more bleeding than what you're used to with a normal period. Most of the time you'll see some increased cramping and bleeding, which tends to come to a little bit of a peak, which sometimes lasts a few hours where you'll have the most amount of discomfort. You may see tissue pass and you'll have the most amount of bleeding. This then resolves as the tissue comes out and the bleeding slows down. You may continue to have some period-like bleeding or lighter bleeding for a few days afterwards. Now, expectant management is successful about 80% of the time, which is a pretty good statistic, and that considers that you're given up to 8 weeks for that process to start. It's noted that you can give up to 8 weeks for this process to start, although most clinicians will suggest a little bit less time. Expectant management is more likely to be successful if you've already started to show some signs of spontaneous miscarriage, meaning a little bit of bleeding, cramping, or if you've had some signs via ultrasound that some of the tissue has come out but some is still in place. If you've already started some of that process, you're more likely to be successful with expectant management than if you've not seen any symptoms at all and you've just had an ultrasound showing that the intrauterine pregnancy is not viable. Now, if you choose to undergo expectant management, once you have seen passage of tissue and bleeding and cramping, which has slowed down and resolved, you should have some form of confirming that the pregnancy has been completely expelled. This is usually done with an ultrasound, but some practices will use your beta HCG levels and trend them down to 0 to ensure that everything has resolved. Now, if expectant management fails, meaning that some tissue comes out but not all of it, or just nothing ever happens at all to start to expel that tissue, you would have the other 2 options that are given for follow-up. And anytime we do something more expectant, whether it's expectant management or option 2, which is medical management, there's always the potential to need the 3rd option, which is surgical management, to completely resolve the pregnancy. So option 2 is a medical management option. This means that your physician can give you a medicine to kickstart that process of your uterus clamping down, contracting, and pushing out the tissue. The advantage of this choice is that you have an idea of when it's going to happen because you know when you're going to take the medication. You're not just waiting for something to occur, which may take a few days to weeks, and it will shorten the interval from when the loss is diagnosed to when everything is resolved. The medication management does result in an increased rate rate of complete expulsion of the pregnancy tissue with an overall success rate of about 84%. Now, the side effects of this medication, which is misoprostol or Cytotec, is diarrhea, because generally a larger dose is recommended, which can lead to a side effect of diarrhea when it's taken by mouth. You can also place it vaginally, which works just as well, if not possibly better, and should avoid that side effect of diarrhea. Keep in mind that you can expect those same symptoms of heavier cramping and heavier bleeding than what you see with a menstrual cycle. And this does continue with the additional risk of, if it doesn't completely resolve the pregnancy and completely expel the tissue, you may require surgical management to completely resolve the pregnancy. So option 3 is a surgical option, and the procedure that is done for this situation is called a suction dilation and curettage, or suction D&C. And in this procedure, a suction curette is placed in the uterus and a vacuum procedure is done to remove the tissue from the uterus. So what would be an advantage of this over the others? One thing would be that it is immediate. You go in for your surgery whenever it's scheduled and you go to sleep or are heavily sedated and everything is done. There's a 99% success rate with a suction D&C. Now, the downside is that there are risks to surgery. So anesthesia and sedation related risks. There's a small risk of forming adhesive tissue in the uterus. Anytime there's instrumentation placed in the uterus, there's a chance of forming some scar tissue in there. This can cause problems with future pregnancies, but I will note that that's very uncommon to see happen. We do tons of suction D&Cs, tons of different types of D&Cs, and it's not often that we see that scar tissue form, but it is a risk to be keeping in the back of your mind. Another risk of the suction D&C is something called uterine perforation, which is when one of the instruments that's placed in the uterus to perform the procedure accidentally makes a hole in the uterus and causes a little bit of a defect damage to the wall of the uterus. Now, this will generally heal. These are something that often no additional treatment's warranted, but that is another possible risk of the procedure. Now, as I mentioned before, if option 1, expectant management, or option 2, medical management, are not successful, option 3, the surgical management, is the kind of last resort to resolve the pregnancy. So sometimes you'll see these being an indication because of a failed different option. The surgical option is also more strongly indicated if someone's undergoing an incomplete miscarriage, meaning that the pregnancy is not viable, they've started passing some of the tissue, and they're having heavy bleeding, or they're hemodynamically unstable, meaning that they have low blood pressure, or they're tachycardic, or they're showing some signs of instability because of the amount of blood loss. In those situations, it's not appropriate to just do expectant management, and a surgical option may be preferred over medical option because of how rapidly it can resolve that situation. So which option is the best one? The answer is that vastly in most cases, it's really up to the patient. Some people prefer to avoid surgery. They don't want to deal with any anesthesia, surgical procedure. They would like everything to be as natural as possible. Some people don't want to wait for their body to figure out what's going on, and they want to know that this is the date I'm having the procedure, this is when everything's done. And some people fall somewhere in between. They're okay, going through the process of passing tissue and bleeding and cramping at home, but maybe don't quite want to go through with the surgery. Everybody's very different in their preferences, and for the most part, there's no one method that's the best, just as a blanket statement. It really just depends on the patient's certain situation, of course, and then what they prefer. I hope that this information is helpful for you to think about. When you go to an appointment like this, it's very easy to be overwhelmed with the information and forget some of these different details. So this would be a good reference for you to look at as you're trying to make this decision. Best of luck to you, and I'll see you next time.